Okay, so let's step into the shoes of a clinical detective. Imagine this. Someone has a mysterious spell, a totally unexplained event, and you're the neurologist called in to solve the case. It's a real-life medical mystery. So, how do you do it? We're going to dive into how neurologists figure out what's a real seizure, what's an imposter, and how they ultimately crack the case.
So here's our game plan. First up, we'll tackle the big question, seizure or epilepsy. Then we'll see how the patient's story is packed with clues. After that, we'll learn to spot the fakes, the seizure mimics. Then it's on to the high-tech tools of the trade, and finally, we'll cover the all-important treatment and safety plan. Let's get started.
All right, Section 1. Seizure versus epilepsy. You know, every investigation has to start somewhere, right? And for a neurologist, the very first question is this. Was that event a one-time thing, like a single rogue electrical storm in the brain? Or is there something else going on that makes more storms likely?
And this is really the core distinction. So think of it this way. A seizure is the event. It's that single crazy burst of electrical activity in the brain, like a lightning strike, just one flash. But epilepsy, that's the underlying condition. It's the stormy weather that makes more lightning strikes likely to happen. It's the tendency to have these seizures again and again without a clear trigger. Now, this is where things get super interesting. You might think, okay, epilepsy means you've had lots of seizures. And that used to be the case. But now there's something called the 60% rule. This means a neurologist can actually diagnose epilepsy after just one unprovoked seizure, but only if the risk of having another one in the next 10 years is at least 60%. So let's say an MRI shows a scar on the brain from an old stroke. Well, that scar can be a trigger point, and that dramatically raises the odds, right? So it makes sense to start treatment sooner rather than later. But, and this is a huge but, it's absolutely crucial to know that not all seizures mean epilepsy. You've got what's called a provoked seizure, and that's a completely different animal. This is when the brain is just reacting to some immediate temporary problem. Think like dangerously low blood sugar, alcohol withdrawal, or a really high fever. Once you fix that underlying problem, the seizure risk just disappears. That is not epilepsy.
Okay, on to our next section, gathering the evidence. Because the story holds the clues. So you've figured out the basic possibilities. Where do you turn next as the detective? You might think it's time for some fancy brain scan, but nope. The first and most powerful tool isn't a machine at all. It's the story.
And this quote really says it all, doesn't it? The history, the story, is almost always more important than the physical exam. Why? Because the person who actually had the seizure, they often have zero memory of the event. It's just a blank space. So the accounts from witnesses, family, friends, the paramedics who showed up, that testimony is golden. They were the eyes and ears at the crime scene, and they hold all the crucial details. And those details from the story, they are packed with incredible clues. The fancy term for this is semiology. It's basically the study of the specific signs a seizure produces. And these signs act just like fingerprints. They can help the neurologist pinpoint exactly where in the brain the seizure kicked off. For instance, if a witness says the person was just staring blankly and smacking their lips, or if the person remembers a weird rising feeling in their stomach, like butterflies, that screams temporal lobe. What about really bizarre stuff like bicycling their legs in their sleep? That points to the frontal lobe. And if they saw flashing lights or colors, well, that's a dead giveaway for the occipital lobe, right at the back of the brain.
All right, Section 3, identifying the imposters. This is a super important step in the investigation. You have to rule out the mimics. See, there are a bunch of other medical conditions that can look exactly like a seizure, and a good clinical detective has to know how to spot the fakes.
Okay, let's talk about a big one, syncope, or just plain fainting. Sometimes when someone faints, their body can jerk a little, and it can really look like a seizure. But here is an amazing clinical clue. If they bit their tongue, you have to ask where. If they bit the side of their tongue, that is a huge clue for a generalized seizure. But if they just bit the very tip of their tongue, that's way more common with fainting. It's such a tiny detail, but it has massive diagnostic power.
Another major imposter is something called a psychogenic non-epileptic seizure, or PNES for short. And with these, one of the most reliable clues is the eyes. In a true epileptic seizure, the eyes are almost always open. But in PNES, the eyes are often squeezed forcefully shut. It's almost like the person is resisting having them opened. The movements are another giveaway. In PNES, they're often more chaotic, kind of flailing from side to side, not the rhythmic, stereotype movements you see in epilepsy.
So now we're at section 4, the confirmatory tests. Okay, the story's been told, you've considered the imposters. Now it's time to bring in the big guns, the tools of the trade. These are the objective tests that help confirm what the detective suspects.
First up is the EEG, the test that listens to the brain's electrical waves. But here's the thing that surprises a lot of people. A standard 20-minute EEG is, well, it's not a perfect test, not by a long shot. In fact, its sensitivity is pretty low. It only picks up on abnormalities about 30 to 50% of the time. The analogy I love is that it's like going fishing in the ocean for just 20 minutes. You might not catch anything, but it doesn't mean there are no fish in there.
So, if you remember one thing about the EEG, let it be this. A normal EEG absolutely does not exclude epilepsy. I'll say it again. A normal test does not mean you're in the clear. It's just a tiny snapshot in time. The brain's electrical storm just didn't happen to be brewing during those 20 minutes.
Next up is the MRI. Think of this as the detective's map of the crime scene. But listen, not just any old brain MRI will do. A neurologist will order a special epilepsy protocol MRI. This version has super high-resolution images that zoom right in on the areas where seizures often start, like the hippocampus. And they also have to be really careful because right after a big seizure, the brain can actually be a bit swollen in that area, and on the scan, it can look a lot like a stroke. It's a classic red herring they have to watch out for.
And that brings us to our final section, the action plan. Because once the detective has a diagnosis, the focus shifts right away to what we're going to do about it. This is all about treatment and, most importantly, safety.
Okay, let's talk about a true medical emergency. If a seizure goes on for more than 5 minutes, it gets a scary name, status epilepticus. And when this happens, there's a very clear step-by-step protocol. Step 1, you hit it hard and fast with an IV benzodiazepine, something like lorazepam, to stop it now. If the seizure keeps going, you move to Step 2, a different, longer-acting IV medication. And if that still doesn't work, that's when you go to Step 3. You put the patient into a medically induced coma with continuous EEG monitoring to let the brain calm down and prevent permanent damage.
And then there's the safety counseling. This part is absolutely non-negotiable. This is all about preventing serious injury or even death if another seizure were to happen unexpectedly. That means no driving, usually for at least 6 to 12 months after a seizure. It means you can't swim or even take a bath alone. You've got to avoid working up high on ladders or scaffolding and be super careful around things like open fires or heavy machinery. It's just common sense, but it's life-saving.
You know, in a perfect world, the first medication a patient tries works like a charm, the seizures stop, and there are no side effects. But we don't live in a perfect world, and that doesn't always happen. So, that leads to the big question, what happens when the first couple of medications just don't work? What's the next step for the clinical detective?
Well, here's the answer. When a patient has tried 2 different appropriate medications and they still aren't seizure-free, their condition gets a new name, refractory epilepsy. And at this point, the case gets escalated. This is the moment they get referred to a comprehensive epilepsy center. These are places that have advanced options way beyond just pills. We're talking about things like brain surgery, nerve stimulation devices, or even laser therapy. The initial investigation might be done, but the detective's work isn't over. It just means it's time to bring in the specialist team.